Good afternoon and welcome to this inaugural meeting of the Retina chapter of the College of Ophthalmologists Academy of Medicine. It is good to note that at least 45 participants are already on. I hope a few more will come. As you know, the Retina chapter has been formalized and we are actively involved in organizing educational activities. And this webinar is the first one of its kind, and I think there are many more coming down the line. For today, I'd like to welcome our President of the Retina chapter, Professor Dr. Mae-Lynn Caterine. She is the vitreoretinal surgeon and consultant ophthalmologist, Department of Ophthalmology, Faculty of Medicine, UKM, and Specialist Center. Of course, you know it's no introduction, but for the new trainees, you will know that she's a well-known teacher. And we are pleased to have her with us today to share with us the management of floaters vitreoretinal perspective. Over to you, Mae-Lynn.
Dr. Paul, thank you so much for that very, very kind introduction. And I'm so very honored to have Dr. Pall Singh, who is the first president of our College of Ophthalmologists with us. He happens to be still extremely active, and he now holds the honorary treasurer position in the chapter. And we are really, really privileged to be together here to welcome all of you, because this is the first time that the College CPD series is free for all our trainees and ophthalmologists who are members of the College of Ophthalmologists and the Malaysian Society of Ophthalmology. So I really hope that you will enjoy this session. It's going to be, I hope, a little bit laid back in the sense that we're looking at a symptom that perhaps we've encountered in our patients previously. But I don't think that there is a dedicated chapter on this, but it's still something that is both common, interesting, and can indicate some sight-threatening or life-threatening causes behind it. And we'll spend some time looking at the what we might consider as benign floaters from posterior vitreous detachment, but it can be very troublesome for our patients. So let's look at what we can do about it. Now, as in the fashion of our chapter series, I would like to start with a poll. I've learned this from our dear member, Professor Zunaina, who actually likes to give the quizzes at the beginning to see what is the audience understanding of the topic. But no worries, please do participate. Lisa, can we have the first poll? So let's just start with something interactive. I believe that many of those who are joining us here are trainees, and some are fellows, and perhaps some even from general ophthalmology or even vitreoretinal background. So nevertheless, let's just look in more detail at this topic of floaters, okay? So in relation to floaters, I'm just going to ask everybody to select. I hope we can get the poll up. If not, I can just share the PowerPoint, I think.
Pool number 1, Prof. Mae-Lynn?
Yeah. So there's about 8 questions for you to ponder on, and we can see what people think would be the correct response for this question. So the first one is that floaters may be caused by the presence of the following in the vitreous except. Okay, so if you look at the list here, you're given RBC, WBC, RPE, calcium, and silicone oil. You must select the option which doesn't produce floaters, even though it might be present in the vitreous. Don't select something that will cause a floater. Yeah. So you have to select something that doesn't cause floaters. So I see that people are coming in with their answers. Okay, and we've already given them the answer here, and we'll soon understand from the top why is that. But I can see that many selected RPE. Now, we'll look into this in the talk. Can we have poll number 2? Can we see the poll number 2? Okay, so we will learn in the course of the talk what produces the symptom of floaters if it's present in the vitreous. Now, white cells in the vitreous may be seen in the following conditions except. So white cells, yeah, leukocytes, lymphocytes in the vitreous can be seen in the following conditions except. So you select the one that you don't expect to see any white cells. Okay, I can see people or the audience participating. This is excellent. And I think, are we still having people put their selection in? Okay, so you would not expect to see white cells in a patient with just PVD. Okay, yeah. So if it has PVD with a tear, you might get the tobacco dust. So you probably wouldn't get white cells. You might get red cells. So yeah, it's such. Okay, can we go to the third poll? I hope you will take part and test your knowledge. Later on, we will see what the answers are from the talk. So vitreous hemorrhage is in a patient following flashes and floaters typically will indicate. So the patient has flashes and floaters initially, right? And there's a vitreous hemorrhage that can be observed. So if the patient has both flashes and floaters, what would that hemorrhage indicate? So interestingly, some people are selecting also tractional retinal detachment. And some selected posterior vitreous, but take note of the symptoms that are being reported here. All right, last couple of seconds for you to put your answers in. And the answer should be retinal tear, yeah, because of the symptom of flashes, yeah. Okay, can we move on to the poll number 4? And this one is on indications for vitrectomy due to floaters in the background of proliferative diabetic retinopathy. Yeah, so this would require us to know the indications for vitrectomy when PDR is the underlying cause. In other words, I think the floaters would be definitely due to vitreous hemorrhage. Remember to choose the one that it's not indicated for. So you would not select the ones that are an indication in a patient with PDR, and select the one where you may not proceed for vitrectomy. Okay, because it's sparing the macula. So poll number 5, whereas the others, we will go through this as well. So I think the key there in that question was sparing the macula. So this one is for those that do read very, very widely, but essentially it's on a survey which was published on a community sample of smartphone users. And it was from several countries by web. And the survey reported the following. So 4 of the statements are correct, but 1 is incorrect. So if you read through the options, so 11 times more likely to report severe floaters. The correct answer is that the floater prevalence was significantly affected by age. It was not. So we'll look in more detail at this interesting community study as well. And we move on to poll number 6. I can see that more people are participating in the poll now. I hope that the others will take the opportunity to also participate. It doesn't matter. This is the pre-test, isn't it? The pre-lecture poll. So it's totally fine to be unsure about the answers and just make your best selection. So options for management of vitreous floaters in PVD include the following except. So these are all the options, and I think the majority have identified we don't use anti-VEGF, in PVD related vitreous floaters. Can we do observe them if they don't trouble the patient? Okay, move to poll 7. We just got 2 more polls, and then we will be able to proceed on to my session sharing in the lecture. So complications of laser vitreolysis. So here's an interesting new term, vision degrading myodysopsia, all right, which is symptomatic floaters, okay, includes the following except. So if we did a laser vitreolysis, now you may not know much about it, but some of you may have read something about it. So if what are some of the complications we need to tell our patients about? All right. So you would select the one that doesn't apply in this situation. Laser vitreolysis is typically not a surgical procedure, it's a laser procedure, all right, using a contact lens and a laser setup. In this case, it's a gag laser with some modifications. Nevertheless, it just uses the same sort of contact lens you use in your patients. I don't know how many of you induce subconjunctival hemorrhages, but I don't think they're very common to have. And so I would be more keen to advise the patient on the other complications. How about poll number 8? This is the last one. Complications of core vitrectomy for floaters may include. So you select the one that applies. This is just core vitrectomy. Yeah, you're doing a core vitrectomy for floaters in a patient who is very symptomatic despite vitreolysis or observation, and the patient may be selected this option. So this is interesting because essentially in a typical vitrectomy, I don't think it could be much inclined to even touch the lens, nor do we induce a posterior capsular opacification, although we may well treat it at the same time. And it's rarely after vitrectomy IOPs go up much, especially in a routine simple core vitrectomy for floaters. And peripapillary atrophy is, essentially something that's a feature of myopia, right? So it's interesting that the answer is myopic foveoschisis may actually progress. And this is something I would love to share with you later on in the talk. So we can stop the poll now. And if you have any burning questions, I think they will can be put in the chat or might have to wait till the end of the talk. So Dr. Paul, I'll proceed with sharing my screen and my talk then.
Yeah. All right, may I know if you can see my slide? All right, and I'm trying to go to presentation view. May I know if you can see the presentation view? And everyone can hear me well?
Yes, Prof.
Okay. So without further ado, let me share with you my presentation on management of floaters, which is a sort of a perspective from the vitreoretinal surgeon side. Yeah. So my only disclosure is that I have given a talk on laser vitreolysis from Alex company before, and that was in the past APAO meeting. Other than that, I've nothing really to disclose. So in this talk, we will try and overview the causes and management of floaters. And let's look at the evidence that is available for floater treatment due to posterior vitreous detachment. And from several interesting or illustrative cases and videos, I hope to share with you some learning points of my journey in treating patients with floaters. So let's just start with a simple question of what exactly are these floaters? Now, the Latin word is muscae volitan. I'm not sure if I'm pronouncing it correctly, but essentially floaters are defined as small dark spots or lines that you see in your vision. They tend to move around. And it's something also known as photopsia. It's a kind of entoptic phenomenon. Now, those taking your part one will probably remember the term entoptic phenomenon, which means a visual effect where the source is within the human eye itself. And remember that under suitable light conditions, where light falls on the eye, you may render visible objects within the eye itself, right? So these perceptions are called entoptical, and this is quoting a scientist, Hermann Ludwig Ferdinand von Helmholtz, okay, from Germany. And so many years ago, they have already identified these entoptical phenomena, which includes floaters. And you can see that other examples include blue field entoptic phenomenon. You may have heard about Purkinje images or Purkinje tree, such as this shown here, or even the Hardinger's brushes. Now, you'll see part one. If you want to read furthermore, please do so, because this is something that comes perhaps under the understanding basic. Yeah. Now, the origin of floaters arises, as mentioned, from objects that are within the vitreous. So if you have anything in the anterior segment, cells, blood, they will not cause floaters. So a situation of anterior uveitis would not typically cause floaters, exception being if the inflammatory cells then were moved on to the anterior vitreous cavity. Yeah, then you would essentially have those shadows cast on the retina. Otherwise, if you have floaters, usually we look very hard for the origin within the vitreous cavity. And it's essentially due to light that bends as it passes through the eye. When it hits a floater, it will bend at that junction. And sometimes the vitreous gel itself will have some fluid pockets. Example, the syneretic vitreous change that occurs with aging. So this is how you cast that shadow onto the retina. And the patient sees it most commonly when they look perhaps at the sky or at a white wall that is very brightly lit, then they will see the shadow as this floater. So now in practice, when it comes to general medical knowledge regarding floaters, basically I took this from one of the guidebooks for general practitioners or non-ophthalmology residents. Essentially, they are supposed to take a recording has not. So the duration of the symptoms, if it's more than 2 weeks, they refer to the outpatient ophthalmology upon the discharge. If concerned for urgent and new processes, yeah, then they will inquire as to the patient, whether the patient also sees these flashing lights or colorful light spots. Because if they do see that, then it's possible that the floaters are actually neurologic. For example, the migraine, you can get that scintillating scotoma. Or it could be even a psychiatric or anxiety diagnosis. However, if they don't see those colorful light spots, they are to inquire whether it is a unilateral or bilateral condition. Bilateral conditions essentially indicate perhaps a systemic infection or malignancy. And if that's the case, they will have to refer to ophthalmology. But if they have excluded this kind of background in the medical side, then they would still consider these neurologic or psychiatric causes. Okay. Now, if it is in a single eye of recent onset with light flashes in the periphery, then again they refer to ophthalmology. But if there are no flashes, then the floaters are considered constant or intermittent. If they are constant, it refers to ophthalmology again. But if they're only intermittent, then they will consider this is not sort of like urgent for referral to ophthalmology. So this is just the background of how our medical colleagues may approach a patient presenting to them. But when it comes to us, then what should we be considering? So back again, looking at the laterality, I think it's a quite useful thing to take note, whether these floaters are in both eyes or in one eye. Let's look at the unilateral causes. These are essentially more or less ocular in origin in most of the cases. Then we ask whether there's any flashes as an accompanying symptom as well. And if there are flashes, then we think of what I always say, to remember those three processes sometimes occur one after the other. Namely, you start off with a posterior vitreous detachment, usually precipitated either as a part of natural aging. It could be following intraocular surgery, such as cataract surgery. It could be after trauma. And the vitreous gel then contracts, and you may get a retinal tear. And sometimes you will get vitreous hemorrhage as well. And another cause afterwards, the tear then develop, the patient will then develop a autogenous retinal detachment. If there is no flashes at all, then you might want to consider the systemic causes, which I will detail later, including such things as endophthalmitis, which is an infection which can be either exogenous or endogenous in origin. One of the posterior or intermediate uveitis in particular may be one of the underlying causes. And this can be either infective or non-infective in origin. Now, under vitreous hemorrhage, we would be considering whether there could be proliferative changes, proliferative retinopathies, usually with underlying diabetes, perhaps vein occlusion, either branch or central, or other causes of inflammation that can result in vasculitis and neovascularization. So this is just a quick overview of the approach to floaters that you may wish to take note of. It, of course, does not exclude all the cases, because sometimes we can't really find these other causes, but this could actually be masquerade either primary lymphoma, for example, or even a metastasis to the choroid. So the red alert on floaters will definitely be to make sure we don't miss sight or life-threatening causes, including things like vitreous hemorrhage, retinal tear, retinal detachment. You can have PDR, neovascularization, and all those causes I mentioned, including acute or chronic endoph, and even masquerade. Now, the non-sight threatening causes will be like PVD or vitreous synovitis, which may still be troubling to the patient, and we'll look at those later. So for floaters, I think apart from taking a very thorough history that can guide us into one of these possible differentials, I think when examining the patient, one of the things that is often omitted or forgotten is the anterior vitreous examination. We very, very quickly look at the lens and quickly then try and look at the fundus. But I think when a patient complains of floaters, it is really mandatory to examine this part of the eye. So you would be looking in the anterior vitreous for evidence of leukocytes, such as, for example, intermediate uveitis, where you can see these whitish cells suspended in the vitreous cavity. You could also get, in a situation of perhaps a lymphoma, B-cell lymphoma, you could get these sheet of cells as well. And in a patient who may have a retinal tear or autogenous retinal detachment, you can actually get this transillumination effect where you see these spots. But more telling will be when you actually look at the vitreous, you see these slightly larger cells with a tan-colored appearance, and we like to call these tobacco dust. Yeah, so tobacco dusting could indicate there is a tear. And of course, we can also have the erythrocytes that tend to be smaller and can be very, very dense in their arrangement in the posterior vitreous. Just a point to make note that you can also see in the vitreous in some patients this condition called asteroid hyalosis or schisis scintillans. Okay, now asteroid hyalosis is that calcium suspension that I told you about. It actually doesn't cause the patient to have floaters, but it really disturbs us when we want to look at the fundus. As for the schisis scintillans, that is actually for the cholesterol. I'll put my video off to facilitate the connection. So it could also cause the patient's difficulty for us to see the fundus, but the patient would not be complaining of floaters. Yeah. And even on OCT, if you're looking at the above the retina, sometimes we forget to look for it. We're always looking for vitreomacular attraction or something else, or membranes. But just looking at the vitreous interface can actually be very, very helpful, because you can see things like PVD and vitreous synovitis shown here, and you can also take note of these opacities. And sometimes I like to look at this because it's very useful to show the patient that you've cleared their vitreous opacities, for example, through vitrectomy. Or if a patient has posterior uveitis with cells in the vitreous cavity, when we do treat them and they improve, then we can actually use this OCT image to help us determine the effectiveness of our treatment, especially at the posterior aspect of the eye. And so let's just go through some of the management principles for flashes and floaters, for example, which are due to PVD. So in this situation, we would take the measure, having excluded all other abnormalities, a reassurance sort of stance. We want the patient to watch out for complications because they could actually ultimately be having a tear which was not immediately visible, or they could develop it later because PVD, although there is some aspect of an acute PVD, but it doesn't become complete all at once. It slowly progresses further on. PVD. So normally if a patient has acute PVD symptoms, if it is happening in the preceding 3 months, their symptoms are in the preceding 3 months, I normally will reassure them. For instance, I had a senior anesthetist come and see me, complaining of very sudden onset of floaters. And these were very large floaters that certainly came to the center and were very troubling to her. But they were very recent, only about 2 weeks in duration. After ensuring that there were no retinal tears, no detachment, we observed her, and within 2 weeks later, that entire large floater had totally disappeared. So essentially, it was part of the acute PVD coming down the gel, then contracting anteriorly as is normal, and the symptoms went away. So there was no need to rush in for a treatment. Now, sometimes the, of course, patient may be having a retinal tear as a result of the PVD, and in small subclinical retinal detachment areas, we can actually barricade the tear or the detachment as long as it is away outside of the posterior pole. We can use both laser or cryo, but of course, we try to avoid cryotherapy, especially in large tears, because when we apply the cryotherapy, the retinal pigment epithelial cells come out into the vitreous, and they can ultimately result in epiretinal membranes and other manifestations of proliferative vitreoretinopathy. When there is a significant retinal detachment, clinically visible, then we resort to our routine options of either pneumatic retinopexy, sclerobuckle, which can be combined with vitrectomy or plain vitrectomy with cryo or laser, and gas or slick monofoil tamponades. It is not the purpose of this talk to go into details, and I hope you will read on for the various indications. It is definitely worth an entire talk to go into the management of these conditions. But what is something interesting I've observed is that when I successfully buckled my patient, the floaters were still troubling him. And I had one patient where I did a sclerobuckle followed by some pneumatic retinopexy to ensure that the break was well sealed and the retinal detachment disappeared. But the patient had to come back to see me because he was having floaters and he underwent many sessions of vitreolysis for that. Floaters due to PDR or other proliferative retinopathy, as samples, ischemic BRVO or CRVO, we still need to treat the underlying cause. But essentially, when there is floaters and this is due to vitreous hemorrhage, you know it is ischemic. And so you really have to treat with either retinal photocoagulation or anti-VEGF. So these are the mainstays of treatment. Now I'm referring here to PDR when I say that protocol S supports the use of either anti-VEGF or laser PRP, with some visual acuity advantages for anti-VEGF and certainly the advantage of a more improved visual field and less night blindness compared to PRP patients. And of course, if the patient has diabetic macular edema, anti-VEGF would definitely be something we would offer to the patient. Yeah. And however, if you notice that the floaters are not small and they obscure the retina, then you would have to discuss pars plana vitrectomy with the patient. And here are those indications that you recognize. So one is if there is a fresh red vitreous hemorrhage in type 1 patient, the evidence suggests that early vitrectomy is advantageous compared to a more delayed situation in a patient with type 2. Nevertheless, either type 1 or type 2, if the patient has never had any PRP laser before and there is no view to give it, then I think those patients should not be made to wait, whether they are type 1 or type 2, because the ongoing ischemia will result in further new vessels and membrane formation. Another indication would be if the retina was not completely lasered due to persistent dense inferior vitreous hemorrhage and evidence of PDR progressing was noted. Another indication will be if there is an accompanying tractional retinal detachment that is large or involving the macula. Then you need OCT monitoring, and certainly proceed on if it is already involving the fovea. And for rubeosis, now why I mentioned rubeosis iridis is even though you may have lasered the patient, rubeosis is still developing. So then entering with a vitrectomy allows us to complete the PRP more effectively and remove the vitreous hemorrhages that may be obscuring the view to give the adequate laser. And of course, ghost cell glaucoma is another interesting condition where the vitreous hemorrhage, the red blood cells are trying to exit the eye through the anterior segment through the angle, and it's actually blocking it. So you get a condition called ghost cell because the cells no longer really have the hemoglobin red pigment, but they all clog up the trabecular meshwork and the eye pressure goes up. So certainly you will need to remove these residual cells in a vitrectomy situation. And of course, if the macula has some form of traction or membrane, which is affecting the patient's vision. So these are some indications for vitrectomy in the context of PDR and floaters. I just want to take an aside now to share with you an interesting case. Now, this case is to highlight the usage of new therapies. You know, we were talking about the anti-VEGF, right? So I have this patient, very interesting, that despite, he says, despite having so many of your injections, my vision is not better. Now, this is Mr. W, 48 years old, actually engineer. And unfortunately, he lost his right eye to a very severe uveitis prior to this. Now, he was a diabetic on oral hypoglycemics, not too bad in terms of its control, but a strong family history of diabetes. And his left eye, which was his good eye, had been going downwards for the last 1 month. Elsewhere, he had received anti-VEGF treatments. Understandably, he has got PDR and DME, and they were trying to relieve the problems of the DME. And they started a new agent as well 2 months previously. He said after he received the injection, there wasn't much improvement, but there was more floaters and more photophobia. So, of course, we get a reverse RAPD seen in the left eye. It should be reverse, sorry, not RAPD, because the right eye, I will soon show to you why we need to do a reverse. His left eye vision was 636. You can see that his control is really quite good. So it's not a systemic issue here. But what is observed is that apart from the right eye, which has occlusal pupillae with a membrane over there, that's why we can't check RAPD. The right eye has an RAPD, but we detect it with reverse using the left eye. And you can see that the anterior segment looks quite unremarkable, really. But there are actually cells, not so well shown here, with a cataract there. What is interesting is the fundus findings, where there is hazy vitreous with vitritis 1+. Now, this is where it's quite important to examine that. But again, with a lenticular opacity, this can be a bit challenging to determine what type of cells are in the vitreous. You can confirm the vitritis with these scans. But what is otherwise observed here is the sclerosed vessels that can be seen moving out to the periphery. All the dot and blot hemorrhages appear to fit with the diabetic retinopathy, but he's also got these cottonwool spots. Sure, the macula is dull with some heart exudates, and OCT will show macular edema, but it's written no obvious retinal neovascularization. But when we do the fluorescein angiogram, this is what we see. Now, what is striking in this left eye is that there is large areas of capillary fallouts in the periphery. You can see these vessels. They do not fill in the periphery at all. And when you compare that with the later stages, you can see that there is actually leakage from the vessels. And of course, at the disc as well, there's some leakage there. And this really is very, very consistent with hot disc, capillary fallout, and vasculitic-like changes in the vessels. So if we're thinking about some of the new agents that are available, one of them is brolucizumab. And please always remember when you're using new agents to reflect back on what might be some of the side effects. And so this patient actually underwent urgent oral corticosteroids and peripheral PRP laser guided by the fluorescein angiogram. So again, a reminder that now people are using anti-VEGF agents both for AMD as well as DME. I think it's necessary to also remember that diabetic patients can have a reaction, a similar sort of inducement of this reaction of intraocular inflammation, especially when you see the right eye already has history of uveitis. I would steer clear of this drug. How about floaters due to infection? Let's look at the condition of exogenous endophthalmitis. I think we're familiar with the red flag signs of pain, decreased vision, which is often accompanied by some floaters prior to it, which are a sign of vitritis, remember? Yeah, and redness of the eye. So it's a dreaded ocular emergency. I think you would get more of it if there was trauma and open globe injuries, followed by trabeculectomy, which is quite a long time of risk because of the presence of the lead. Vitrectomy has quite a low rate in IVT also, but we sometimes see them because we do so many of these other procedures. And certainly I can't overemphasize the importance of not forgetting your intracameral antibiotics in a preventative measure. And attention to patients with immunosuppression. So that's why we control our diabetics very well. I will not do surgery for anyone with above 12. Maybe some people have lower thresholds. Certainly we need to control them prior. We always use iodine to sterilize the surgical field. There's no cutting this. And always observe the lid condition. It is so often omitted because we hone in straight away for the anterior segment. And it would be doing the patient a disservice to not settle their blepharitis or meibomitis prior to surgery. How about endogenous endophthalmitis? I've just touched on a little bit. The signs tend to be more subtle. It's coming from the back, from the choroid, breaking into the retina. So the vitreous floaters are first before you get anterior chamber involvement. And this is something we should always take note of for immunocompromised patients, those with diabetes, liver abscess, or urosepsis. It is good for the physicians to be cautious about this possibility. Sometimes they're unconscious, and that is why they might present late. But treatment is certainly towards the underlying condition. We have available to us CPG on infectious endophthalmitis, and this very, very nicely outlines our approach for acute cases, which usually present within 2 weeks, but it can be up to 6 weeks as a definition. And of course, we examine the patient very well and must do a B-scan because that helps us to monitor the progression and detect loculations, especially when there is no fundus view. Investigations are recommended for TAPs, including, if necessary, an anterior chamber tap within 1 hour. So no delay. It's an ocular emergency. The specimens are therefore sent to the laboratory immediately for gram stain culture sensitivity. And we immediately treat them with the intravitreal antibiotics. And we're not going to wait. I usually give these under some form of local anesthesia because it is a very sore eye, and would not use the same sort of setup like for your intravitreal injection of anti-VEGF. And the reason is that with anti-VEGF patients, I mean, their eyes not inflamed, but in patients who have acute exogenous post-operative infectious endophthalmitis, the eyes are tended, so you need to give them adequate anesthesia. And then we begin the topical antibiotics in a very intensive fashion. I usually wait a while for the gram stain before I do any steroid. And You can see here, there's a comparison to the chronic case where initially the patient would have sort of like a later presentation, similar in terms of the assessments and the tap and the sending of specimens. But in the case of the chronic postoperative case, you may remove the IOL. The organisms tend to have be more indolent, so you could have fungal organisms as well. And the treatment would include, therefore, the antifungal. So this is a comparison of the two algorithms, which you can read in more detail. Not really the purpose of this talk to go in such detail. And oral prednisolone can be considered because we know it is very, very inflammatory. Yeah. And we would only give that when you're very certain, but you can see that it's not recommended for oral prednisolone on the chronic endophthalmitis side. Instead, we would consider systemic antifungals if that organism is detected, or in very severe anterior chamber reaction, then RTPA may be an option. How about the endogenous endophthalmitis? As mentioned before, we have to combine the management with the underlying systemic infection and abscess drainage where necessary, and work together with the physicians. But you can see that we do use some ocular parameters as a guide. So vision is one of them. Hypopyon, APD, certainly if the vision has dropped and you're getting hypopyon, and all these suggest worsening condition to the point of sight threatening, then vitrectomy is one of the options. But it is possible to observe the rest and do the tap biopsy and give vitro if the condition is milder, and to also periodically evaluate them if there were none of these signs of ocular involvement. So how about the evidence that we have now? The early vitrectomy study is the best evidence so far that we have on endophthalmitis. The endophthalmitis vitrectomy study is the best because it was a multi-center study, but its data is from 2003 or thereabouts, so it's quite an old study. Now we have some other suggestions on how to treat endophthalmitis after cataract surgery. And I think what we are now seeing, rather than a pore vitrectomy being performed as advised previously, a more total vitrectomy with PVD. But it should be on a case-by-case basis and with caution, because of course, if you cause a break, this can result in very aggressive PVR. And you can see now that the movement towards the role of early vitrectomy, especially now that our incision sizes are much, much smaller. And we've got better medications that are available to be used. For example, oxyfloxacin, ciprofloxacin, are much better than what we had in the EVS time. And really, we need a new study to tell us whether early vitrectomy is something that we can adopt. But nevertheless, I'll just share to you, some of you may have seen this, those who attended some of the teaching sessions. But I will share this one because I think it's a very nice case illustration of how we do early vitrectomy for a case of endophthalmitis in a patient that actually progressed rather quickly. It was a lady who had an uncomplicated surgery, and she deteriorated over 9 hours, dropping her vision from 624 to 660. And I didn't want it to get worse. I could recognize the signs. We can do it under subcutaneous anesthesia. It is not always necessary to go for general anesthesia. I think you need to manage the initial anterior segment. You put the typical 3 pots and you do your vitreous biopsy because you don't know what organism you're going to get. And you really need to clean up the anterior segment well, because that's where the organism started to enter the eye in this patient after cataract surgery. So I really cleaned up the back, and I used viscoelastic because there is a pupil membrane that has already formed, even though this is about 48 hours after surgery. What you can see here is a very turbid anterior vitreous. So you see lots of the white cells there with cellular debris and entry of white cells into the vitreous cavity. And even though it's only 48 hours after her surgery, with the deterioration, you can actually appreciate these multiple dot and broad hemorrhages distributed throughout the fundus, the PVD is induced very, very gently. This patient is not a diabetic. These changes are not related to diabetes at all. If you see the pus, it's usually found inferiorly, and you should actually clean it up as well as you can. The biome is very useful because it gives you an excellent peripheral view, and you do some indentation in order to clear off the pus as best you can. You trim as best you can, because if you leave too much of this, the organism is inside, it's harboring. But we are careful not to induce a break, so you've got to be very, very cautious about that. This is just showing some indentation and careful trimming of the inferior pus, and need to indent and remove everything that is obvious. I moved to temporal. Okay, this is just more fancy because the original surgery was temporal, so I felt it was more ergonomic to allow me to clean up the capsular bag, and I actually did this by using my Coughlin hook to push back the peripheral iris and to actually irrigate the bag as much as I could. I did not want to remove the lens because I wanted to give her a chance that she could actually, this could be her last surgery necessary. And of course, we do not omit the injection of vancomycin and captazidime, which is my preferred antibiotics following cataract surgery. And everything else is done in a very routine manner, and roxifloxacin for the anterior chamber as well. Now, you can see here that it is certainly a pussy aspirate that we've gotten, and but the anterior segment really clears up, and the contrast between the intraoperative finding and the three months post-operative is startling, and we've actually managed to reverse those fundus findings, which really explain why these patients get RAPD when we operate on them later. The organism just damages the retina so rapidly. Now, what are the other rules for vitrectomy in intraocular inflammation? Basically, if you look under diagnostic, you can see that we can actually find out what is the underlying cause in intraocular inflammation situations. Sometimes we need to biopsy to confirm whether they are having B-cell lymphoma, or if there is a choroidal lesion, which is suggestive of some form of malignancy, we can actually take biopsies. And the therapeutic value of vitrectomy is certainly to remove all the inflammatory membranes that we see. And the indications will be persistent uveitis of unknown cause, tumor sampling, choroidal, and so these are some of the indications. So I just want to share with you an interesting case of acute retinal necrosis in a young Indian lady that was presented to us. We treated her for the underlying problem with antivirals, but the retina responded to the inflammation in this manner, where within 1 month of her treatment, she developed this, you can see here, an extensive membrane overlying her fovea, which led to rhegmatogenous retinal detachment. Now, we really managed them by peeling all these membranes, and in this case, I used a sclerobuckle to support the vitreous base. And this is her appearance after silicone oil insertion. Now, what about this issue of posterior vitreous attachment with vitreous synovitis? Now, this is what we see, what the patient sees when they have floaters in vitreous synovitis. Now, PVD pathology, as well known to some of you, will be the separation of the posterior vitreous cortex from the internal limiting membrane of the retina, in which there is early liquefaction of the vitreous happening. And once it becomes more extensive, there will be actually separation at the vitreoretinal interfaces, bearing in mind that strong adhesions occur at the base, at the optic disc, where you actually perceive a circular floater called a Y-string. Sorry for the background noise. The macula is another area, hence you have the vitreomacular interface disorders, and the blood vessels. That explains why we get vitreous hemorrhages when we have retinal tears, and also at areas of retinal degeneration, where there may be abnormally strong adhesions between vitreous and retina. And this is actually due to the gel structure changing. Now, the symptoms from PVD lead to a condition called vision degrading myodystopsia, or VDM. This refers to clinically significant vitreous floaters that will need therapeutic consideration. Now, how common are floaters? Okay, this is talking about floaters in a community which actually do not have any other eye problems. And this was conducted in 2013 by Webb and his group using an electronic survey of the smartphone app used by 603 respondents from a number of different countries, and was found that 3/4 of the respondents actually had floaters. And 1/3 of them said the vision was blurred. And interestingly, both myopes and hyperopes were more likely to experience severe floaters, as graded by the scale mentioned in the paper. They couldn't identify any particular risk factors, so age, race, gender, and eye color did not seem to affect the incidence of floaters. Now, can we remove these floaters effectively? Let's look at the literature for some of the options. So one of the options that has been published is YAG laser vitreolysis. And this is a randomized clinical trial that came out in JAMA in 2017, in which they compared the floaters treatment from vitreolysis to from sham vitreolysis versus the actual laser vitreolysis to see what was the effect. Now, they classified their floaters according to the International Society of Vitreous Laser Surgery classification, where group 1 is the floaters from attraction, such as the operculum of a tear. Group 2, so this would be very peripheral. Group 2 will be those from posterior hyaloid membrane and braided inner membrane, example, the Weiss ring, yeah, and fibrotic formations. Group 3 will be those from vitreous body, the cortex or the cloacae canal. These tend to be in the form of strings, globuli, nets, and clouds. And group 4 will be just the lens capsule after YAG capsulotomy that often sinks down, or group 5 secondary floaters. Now, in this group of patients, they evaluated whether YAG laser vitreolysis actually was able to free the patient from their symptoms. And this was just a single center, masked, sham-controlled RCT. And they did the intervention for patients in the treatment group. And it was a random assignment for the YAG laser vitreolysis. This is what the machine looks like. It's a neodymium doped. Okay, this is too long for me. It's a YAG laser, okay, which we are familiar with. And it's what we use both in the front of the eye. We can also use it at the back. There is some advancement in the technology, allowing the energy of 7 millijoules to be more focused onto a target in the vitreous cavity through the usage of a number of specially designed lenses. There are a few. The one I'm familiar with is the Caterine lens, but we also have the same vitreous lens, and it's a contact lens, just like any other laser lens you might be using. For the inclusion criteria, generally, symptomatic Weiss ring floaters secondary to PVD would be the most easy to tackle. Duration must be at least 6 months for the reasons I mentioned earlier, where you can actually have self-resolution of acute PVD symptoms. The PVD should be complete. We use our clinical examination to confirm this and confirm with the OCT because it gives us that interface in the vitreous cavity, and also a B-scan to see what is the vitreous doing, whereby self-rated visual disturbance of at least 4, ranging from no symptoms to 10 debilitating. So they had to have some symptoms. And the Weiss ring had to be at least 3 millimeters from the retina and 5 from the posterior capsule on the B-scan. This is to avoid damage to the retina and also to the lens capsule, especially in patients who are phakic. And if the patient's vision in the fellow eye was not normal, then they would not be included. And if there was also any retina pathology. Now, there are 10-point visual disturbance scores that can be used for evaluation, and a 5-point qualitative scale for symptoms. And the patients all answered the National Eye Institute Visual Functioning Questionnaire. And what was the results is that there was significant improvement in visual disturbance measurement in the group that received the laser treatment at 6 months. As for the qualitative visual improvement scale, half of the patients had completely better symptoms. As for quality of life, the main subscales that were improved were general vision, peripheral vision, goal difficulty. So they were managing much better in the goals, and dependency on others all improved with treatment. However, the visual acuity was not significantly affected or changed. And the mass photography found there was improvement up in 94% when comparing the photographs. So in this conclusion from the study is that the vitriolysis improved the wide-strain-related symptoms, the appearance of it, and gave the patient greater some improvement in their quality. But of course, larger confirmatory studies are needed. As for local studies, I have had the privilege to conduct a local study in Hospital Chancellor Tuan Mukris, my colleague Dr. Wanigo and other investigators, in which we found that the laser vitriolysis for a various number of floaters, not limited to wide-strain only, but including the other floater categories, that the contrast sensitivity as a measure of improvement after vitriolysis, it improved the means at 1 month. As for the visual quality of life, there was improvement in the median for the subscales of general vision, near activity, also distance, visual activity, and mental health overall. So these are my tips for those who wish to consider doing vitriolysis. As we know, it does have some improvement for life quality for patients. And we start with pseudo-phakic patients because you would not have the risk of lasering the lens in such situation. It would be recommended not to use a glistening lens implant so that you get better visualization and less glare in your first few cases until you have accustomed to the system. A cooperative patient is definitely a godsend, and they should be able to sit still at the slit lamp for about 20 minutes. Now, when we say 1 hour, it's for the first time. That essentially the procedure takes between 10 to 20 minutes in my hands now. If you can see the retina, then it's probably not safe to fire. You only fire the laser when the floater is clearly seen, and the jet laser, as you may have experienced, uses an aiming beam comprising 4 dots that will actually focus to a single point. And it's good to have vitreoretinal backup in case you do run into any complications. But don't overpromise the patient, because I think in very cloudy large floaters, only 30% of relief is obtained. But with a wide string, the improvement can be as high as 70 to 90%, especially if we can totally remove it. What about some latest evaluation developments? They now have a vitreous floaters functional questionnaire because of the large number of patients that have this condition, in order for us to create vision degrading myodysopsia so that we can determine whether patients really need treatment or not. This questionnaire is more floater specific, has a 100-point scale. And in the study by CBAC and group, they already had 309 patients, which was published just last year in the ARGO meeting, and found that this new questionnaire better correlated with the structure of the vitreous on ultrasound and visual functions. And they actually treated some of these patients with very significantly poor scores, so that the limited vitrectomy that was done improved their visual function questionnaire scores definitely more than the previous NEI VFQ25 questionnaire scheme. So the current treatment options for irritating floaters remain with do nothing, live with it, or consider YAG laser floaterectomy. It's been available since 2016, or pars plana vitrectomy surgery. And we have to look into this condition because we now live in an era, especially where premium lens surgery and high patient expectations is the norm. The treatment outcomes when we look back to back versus vitriolysis and vitrectomy. Vitriolysis gives symptom relief in as much as half of patients, but it really hovers around this range. And the floater removal success rate, well, if you actually have one single floater, this is quite successful, but the larger the floater is, the more sessions you have to do. Nevertheless, it is attractive as definitely a first option for symptomatic floaters because the complication rate is low. You will get some increase in smaller floaters, tears, RDs, retinal hemorrhage, cataract, even cystoid macular edema, overall 0.8%. As for vitrectomy, it is more, the range of relief is much higher and it's very successful, but the rate of serious complications remain formidable. And if the patient gets one of these, then it could lead to vision loss. So that's the problem with vitrectomy. But we have reports that patients are really disturbed. It can even be one report said it's more depressing than macular degeneration, more depressing than diabetic retinopathy or glaucoma, and some very life-threatening conditions even. So in those patients, I think if vitreolysis doesn't give them the relief, then vitrectomy may be an answer, and it's really very effective for removal of the floaters. So a little bit more about vitrectomy for floaters. Here is an article by Dennis Lam and group in which they very interestingly combine the floaterectomy, surgical floaterectomy, to their phaco procedure, making it a two-part PPV in which only anterior and core vitrectomy is done. The patients had 88% floater clearance and quite a high satisfaction rate. But my personal opinion on this condition is that if you don't induce PVD for floaters, the PVD may actually occur later, and then your patient will be left with a recurrence of floaters. So if it is safe to perform, then I think it should be done. And I feel that if you cause a tear, and tears do occur up to 5%, maybe more, you can still treat this intraoperative with gas, and at the end of the day, the floaters will still be relieved. And the patients, even though if you don't do a proper PVD inducement, you may leave behind a vitreous layer. And you cannot avoid this totally, but it will be larger if you don't induce a PVD. And we avoid cutting too close to the lens, and that's the reason why we do have to really leave some vitreous behind, which can cause a vitreous fill. Let's look at some very interesting cases in the last five minutes I have. On a 40-year-old man, he was very disturbed by his left eye floaters. It was more than 6 months. One session of YAG just seemed to make it worse, and he was already anxious and depressed. So I just want to share with you that induction of PVD in a patient who does not actually have PVD present prior to surgery can be challenging, and here are some tricks to achieve it. So this is what we normally do. We put our cutter on simple suction, and we start at optic disc, going along the vessels outwards. We use IVTA, in this case a diluted, perhaps 40% of the original concentration, to stain the posterior vitreous, and then we repeat the procedure with the cutter on suction, and we can also try a soft tip with active extrusion. Other methods include usage of the forceps, ILM forceps, to try and pick up the edge. I feel that if I have difficulty, I will put on a flat lens with a silicone ring. And here you can see that the achievement of the PVD is finally reached with the help of the lens and the IVTA and the vitreous cutter on suction. And then the remaining vitreous is, posterior vitreous is, detachment is induced anteriorly. Thank you very much to my colleague who has helped me with this video. So my learning point from this case is the usage of IVTA, and that various tools can be employed to induce it, and do not give up if you really want to induce it and the patient does not have any floaters afterwards. And should we do more than just induce the PVD? And this is something which totally took me by surprise, having seen that people do just core vitrectomy, etc. So my patient was a 61-year-old patient. The significant ocular history here is the high myopia. He's already had bilateral cataract operations, very successful, good vision, 6, 6, and 6. But he's disturbed by floaters. And even though we did vitreolysis, this wasn't good enough. He had first his left eye PPV, and then the right eye was done 1 month later. We published our findings because something very interesting occurred after the surgery. And the right eye actually gave him a problem first. The right eye at baseline looks like there's some membrane there. After the PPV for the floaters, you can see that there is a progression of the myopic fovea schisis. You can see here the schitic appearance to the retina and the fovea. Now we had to revise his PPV and this time peel both the membrane and the ILM. The left eye also had the same thing happen to it, but this time there was a foveal detachment as well as foveal schisis, and this all came about months after the initial vitrectomy for floaters. Luckily, he got a good result. The last case is another patient who more recently came to me, again having had floaters done elsewhere. We felt that most likely the posterior vitreous was not totally removed because some of it could be seen at optic disc. And the fovea schisis at presentation did not immediately prompt me to do any surgery for him. He had no other symptoms and vision was good. But 6 months later, it was noticed that he was getting foveal detachments in a parafoveal location and something happening at the fovea as well. And finally, after 9 months, we said we can't wait anymore. His vision was slightly dropping, and so we did PPV ILM peel, and the results are coming up later. We don't know yet. He's only just had the surgery 2 weeks ago. So the learning point I got from these patients who had undergone PPV for floaters is that it is very important to do preoperative OCT assessment and consider a complete removal of the posterior hillock combined with ILM peeling in these patients in which there is pre-existing epiretinal membrane or vitromacular traction, because there is a likelihood of progression of the fovea schisis in these patients. We should operate on fovea schisis before foveal detachment, before vision loss, and before development of macular hole, which inevitably occurs if we leave the foveal detachment alone. And we should warn patients about progression if they are going for PPV for floaters, even when there is nothing significant on OCT if they have high myopia. So this is my final take home about floaters. Thank you for listening to this really interesting look at floaters. We should always exclude life and sight-threatening causes by thoroughly taking a history, especially noting the floater laterality and duration. The examination should include anterior vitreous examination, treatment of the underlying causes, so we consider the options of medical, surgical, injection or laser. We have options, and these should be specific to the underlying cause. As for symptoms for the benign causes, especially BDM or vision degrading myodysopsia, we can give a reassurance and wait, especially with recent symptoms. But if the symptoms are longer than 3 months to 6 months and symptomatic, we remove the vitreous opacity through a number of options. We can offer laser vitreolysis, vitrectomy, or vitrectomy with membrane peeling as needed in high myopes. So this is my final take-home message. I've taken various references from the internet and journals, and I wish to acknowledge those who have made this possible, especially the Retina chapter and the Malaysian Society of Ophthalmology and my colleagues. I thank you very much for your attention. Take note my email if you wish to refer patients or discuss any cases. And congratulations, our activity is a first not only for the MSO and Retina chapter patients, but also for the fact that you probably got the first CPD point for the new CPD cycle from this activity. I just want to invite everyone who is coming to the WCBS meeting, the 2-hour surgical retina symposium. And also not to forget our COSC coming up in September. Thank you once again for your very kind attention. Dr. Paul, are there any questions in the chat while Aliza actually will start the poll again?
Yes, I think you have covered exhaustively marathon session on various parts of the vitreous, not only floaters, but you did endophthalmitis and so many others. It was a very thorough presentation by you. I think must congratulate you on this presentation. I think a lot of things were raised and clarified very clearly. I hope the audience enjoyed listening to you. And if they got any problems, we can answer that now.
I'm happy to answer any questions posted live or in the chat. Meanwhile, let's run that poll again and see whether our audience were able to keep up. Nevertheless, I will explain the answers as we go along. Can we quickly have the poll?
Yes, that's a question. Is it safe for a general ophthalmologist to perform vitreolysis? I personally feel that, you must be able to focus it very well. Unless you are very well versed with looking at the vitreous and doing the laser, it can be challenging. What's your views on that, Prof?
I think normally you need to have some training in doing the laser vitreolysis. It can be a little bit tricky. And patients who have had multifocal lenses would be one group, which is tricky. If the pupil is small, again, it's tricky. And patients who are faking, be very careful. Sometimes you can actually mistake that area and go too anteriorly. And the complication that could occur from the vitreolysis includes as mentioned in the talk, a range from tears to hemorrhages and so on. So I think it would be best to refer to someone with some experience. But if you have been trained and supervised with a reasonable number of safe cases, then I think it's okay.
Any other questions?
Thank you for the question. If not, let's run the poll if we could. Meantime, you can also continue to post questions or just unmute and ask a question. Puan Alisa, ada poll tu boleh start tak?
Pool yang mana, Prof?
The same poll as just now.
Okay. So you want to start pool number 1,
Yeah. So here's the poll we tried at the beginning before the talk. So floaters may be caused by presence of the following in the vitreous except. So just select the one that doesn't usually cause any floater. Just now I was able to see the responses, but this one is a little bit different. I can submit my answer, but I couldn't see the responses. Oh wow, okay. So we managed to convince some people that it was the calcium, right? So the asteroid hyalosis, which is comprising calcium, usually does not cause the patient to have floater symptoms, yeah. But the RPE here is referring to the tobacco dust that you get from the retinal tear or rheumatogenic retinal detachment. So actually these actually can, this can be seen in such patient. And the silicone oil is also can cause the patient to have a floater. Yeah. Good. Okay. Can we have the next question? Because as long as they cast shadow on the retina, white cells in the vitreous may be seen in the following conditions, except. All right. So just qualifying what I think most people already know, sympathetic ophthalmitis, you can have posterior uveitis, multiple sclerosis can be associated with intermediate uveitis, of course, endogenous endophthalmitis, the floaters arise from the posterior segment, and acute retinal necrosis is another condition where you get quite aggressive vitreous inflammation. So PVD would be the one where you would not expect to see white cells. Okay, next poll.
Yeah.
Now, okay, poll number 3. Vitreous hemorrhage in a patient, falling flashes and floaters typically indicates. I think they actually got it right even from earlier on. That's really good. And I think most people have, prior to this, selected the key is in the flashes, which is typically associated with movement of the vitreous when it is adherent to a part of the retina. The retina cannot feel, symptom of pain or anything. So anything that irritates it or moves it will give it a symptom of some light perception there. Yeah. So I think we could show the answer now in the interest of time. So thank you for the answer. So the answer is retinal tear. That's very good. Okay, so we move to poll number 4, or question number 4. Indications for vitrectomy in a patient with PDR and floaters includes the following, except. So I was explaining earlier regarding rubeosis, yeah. Well, essentially, if there is rubeosis and you can't complete your PRP, the floaters will be obscuring and it's already rubeosis. I would be inclined to consider doing vitrectomy and laser the vision extensively. Therefore, the answer will be sparing the macular TRDs. Okay, thank you. Next question on poll 5. So this is looking at the prevalence of floaters as reported by a study in the community, right, of smartphone users from a number of countries in 2013. I think they had over 600 respondents. And which of the statement is incorrect? I hope you can see the entire statement. Basically, the the floater in this particular group did not appear to be significantly affected by age. I can see majority have got the right answer this time. It was quite common. 3/4 of just people out there had floated. It's really common, and 1/3 of them had severe ones. And the mean age was young, productive age, and 1/3 had vision impaired due to it, and both myopes and hyperopes. The myopes were 20 times more likely to report severe, whereas hyperopes were 11 times. Thank you. Next one. For Pall 6, options for management of vitreous floaters in PVD include the following, except, okay, yeah, we don't just give anti-VEGF for any particular patient, yeah, without a clear indication and consideration of side effects. I think everyone's got this. Well done. Okay, can we go to Pall 7? That's just brilliant. Let's go to the next, second last question. Complications of laser vitriolysis for VDM include the following, except. So we had a quick look at this one. Fortunately, lower rates than vitrectomy, but nevertheless should be included in counseling. The floater increase is because we break it up. Yeah, we break the big floater up to smaller pieces, and so that's when you get an increase. You could induce a tear, get a hemorrhage if the laser too close to the retina. And I have had that before. Essentially, we just increase the pressure by pressing on the lens, and it's usually innocuous. Yeah. Cataract can also happen in the phakic patient, and we don't usually get subconjunctival hemorrhage from that. Yeah. Okay, next one, the last question. Dr. Paul is good. They're doing very well. I think they managed to pick up. Complications of laser vitriolysis. Complications of core vitrectomy for floaters may include, especially in okay, now usually the core vitrectomy, when we put in our port, it's not common that we will disturb the lens because of our location. 3.5 to 4 millimeters from the lens, then it's unlikely we cause lens subluxation, even in a routine case of vitrectomy. What more floater vitrectomy for floater? Yeah. So, and yeah, you rarely use a capsular opacity. It's not from the vitrectomy. IOP, I mean, if you don't suture, then it's rarely raised, and certainly not peripapillary atrophy. So I think the answer is the progression, because it can happen. It's been seen. If you don't remove the posterior hyaloid, then you may actually encounter this. So I think with that, that is the end of the poll. And Dr. Paul, if there's anything else that we should be addressing.
Yes, thank you for the session. I think very interesting and informative. And I hope there's more audience participation next time. They should send in more questions. But I think your talks are very exhaustive, so they're all stunned by the knowledge. I hope we'll have more sessions like that. And we had a good number of participants, 70, which was very good. I hope we can have more sessions in future. Thank you so much, Prof. And thank you all the participants. And thank you
very much. If people are not shy, they can put on their video cameras. Dr. Paul will, I don't know whether Juan Aliza can help us to take a picture, because this is historic. Retina chapter has done 2 chapter CPD, but this is the first one in which it is free for MSO and college members in general. So it is for the very first time. Yeah. Thank you. I see some putting on their cameras. That's so great. Thank you. Puan Aliza boleh ambil gambar ke?
Boleh, Prof. If everyone is ready.
Yeah. Nice to see some familiar faces. Hello. The trainees and some graduates. Yeah. If you are shy to ask question here, feel free to ask me later on. And also keep reading, yeah, from journals and so on. There's so much new information. There's still many things we do not know. Yeah. And just a little topic like floaters can be can have so many things to discuss and share. Yeah. Thank you for coming. Okay, ready?
Okay, ready, yeah? So 1, 2, 3. Everyone's okay. Everyone smile.
Dah ke?
Okay, Prof.
Okay. So they for the CPD points, they can claim it macam mana?
Yes, I already put into the chat box. You
Oh, okay.
click that link and fill up the Google form so that I can submit the attendance to the MMA.
Thank you so much as well to Puan Aliza and Dr. Paul and everyone.